and will be posted to the HCA ESB 5476 webpage. It is open to public disclosure, so please refrain from disclosing any private or confidential information. Guidelines for public feedback. There will be designated time for public feedback in the last 5 to 20 minutes of the meeting. Each person that wants to share will have 3 minutes to provide their feedback. Non-committee members will remain muted until it is time for that feedback at the end. HCA staff in attendance are asked to refrain from commenting during this time and to bring comments instead to the internal meetings. Feedback that's not provided during this meeting can be submitted via email to HCAESB 5476@hca.wa.gov. All right, so I'll go ahead and pull up the agenda for today. And begin roll call. So I know that there's a few absences, but we'll go ahead and when I say your name, just say here, and I will give a few beats to allow someone to respond. If I miss you, anyone that attends late, we'll capture them in the chat, hopefully. So Michael Langer.
Present.
Amber Leaders.
Good morning.
Morning. Senator Dingra. Senator Braun. Rep Davis.
Good morning.
Morning. Rep Griffey. Caleb Bantagreen.
Good morning. Present.
Sorry, my audio's messed up. Also, Everett Maroon's trying to get on as Malika's designee.
All right. Victor Mendes.
Good morning.
Good morning. Kira Fisher. Alexi Orr.
Here.
Thank you. Amber Daniel.
Present.
Thank you. Brandy Flood.
Present.
Thank you. Cheryl Raysar. Chad Enright.
Present.
Thank you. And John Hayden said he couldn't make it. Marshall Glass. All right. Sherry Candelario.
Oh, sorry, I was muted. Present.
Right. Thanks, Sherry. Hallie Virginal.
Here.
Thanks, Hallie. Teresa Atkinson.
Good morning.
Good morning. Sarah Gillard is not able to make it. Neither is Donnell. Neither is Malika. Addie Adwell.
Present.
Great. Kevin Ballard.
Present.
Hunter McKim. All right. Kendall Simmons.
Here.
Okay, thank you. Rep Taylor. Rep Mossbrucker. Okay, so if people attend later on, hopefully, again, we'll catch them in the chat. So I think the next step is to do some introductions for some new members. So we have a new recovery housing representative as well as a new adult in SUD recovery. So I'll hand it over to you, Michael, for those intros.
Sure. Thank you, Michelle. And we're quite delighted to have Sherry and Victor here with us today. It's great to see your faces and have new perspective come in and join us. I believe that you had a chance to talk to Michelle a little bit about the committee and maybe get caught up to speed on what's happened the first few months. But as our early tradition has been, as we have new members join us, we'll turn it over to you and give you an opportunity to share a little bit about who you are and your interest in serving on the committee. And again, just quite delighted to have you here. We have a lot of work ahead of us. And so having a full complement of committee members is going to go a long way to help us out. So we'll start with Sherry. Do you want to take a moment and take yourself off mute if you're on mute, and just share who you are and what you're looking forward to with the committee?
So I feel like I know a lot of you because I've watched the YouTube videos. It's really an honor to be here. Educationally, I have a doctorate in pharmacology from University of Washington Medical School, and I did research on how to block opioids. The week after I got my PhD, I adopted internationally, and I have firsthand experience with helping a family member through addiction and substance use disorder. And along the way, because I was so closely aligned with helping my daughter, we opened up Kate's House Foundation. We used our own retirement funds to buy several houses in South Seattle. And our goal was to be homes where MAT was allowed, where co-occurring disorders were allowed. And our principal guiding thought from 2015 on is that we would create a family in the home and people would not be allowed to leave for any transgression. And so currently we have now served about 800 people in our homes. We speak nationally on certification standards. We were the first homes that were certified by Walker. And I think the most important thing is we work with everybody from low barrier people coming from drug court to DOC to graduated reentry and disadvantaged women. We have a community in our home and it works. And I'm so honored to be here because I am a firm proponent on quality recovery residences. Thank you.
Thank you, Sherry. And that's very impressive. And just a lot of thank yous, I guess, and appreciation for going above and beyond of what most people do, to give back and to serve those that we're so close to here on this committee and certainly in our work lives, and personal lives for many of us. So thank you for what you do and for, again, agreeing to serve on the committee. One ask I have of yourself and Victor and others, all on the committee, is don't be shy. As we bring up topics and bring up thoughts, we have a divergence of thoughts many times. We have different perspectives, and we need to hear them all. So as questions come up, try to, challenge yourself a little bit and engage in the conversation. I really would like that as a chair. So,
and one more thing, Michael, I did this with my husband, Frank. I can't take credit. It's 50-50.
Yeah. I think I had a chance to meet Frank in the past here, so thank you.
Okay.
Let's move along to Victor Mendes. Victor, if you're on, do you want to introduce yourself as well?
Hello, my name is Victor Mendes. At present, I work for Family Health Centers in Omak, Washington. I work for the Okanagan Community Opioid Overdose Prevention and Education, where I provide Narcan and naloxone training to the community and anyone interested in receiving Narcan and naloxone in hopes of saving lives. And I'm just always interested in learning new things, and that's why I signed up for this committee. And I know a few of you, and I look forward to working with y'all.
Thank you, Victor. As with Sherry, I just really appreciate you committing more time to the cause here and being willing to share your perspective and your experiences. And particularly from the North Central, we don't have a lot of representation from that area. And so being able to talk about what it means when you have a lot of miles between services and folks living remotely and such. So thank you for being on, and the same encouragement is please join in the conversation as we get into it today and some subcommittee work and future meetings. We really want to hear your voice in this process. So thank you.
Thank you
for being on.
Thank you for having me.
Absolutely. I think at this point, we reached out to Hunter and asked him and we'll rotate this around, folks, but we've asked Hunter to start a monthly I don't know what we want to call it, just a protocol, reminding us of our norms and expectations of this group. We collectively developed these, and so we thought we would just read them off as we start each meeting and remind ourselves and kind of set the stage for the conversation. So, Hunter, if you are prepared and on, do you want to review the norms and expectations with us this morning?
Yeah, good morning, everybody. Hope your month went well. Got the committee norms and expectations in front of me, so I'll read them off now. So in here, we assume good and positive intent from everyone. We consider diversity, equity, inclusion, and tribal impacts in the work that we are doing. And we offer both, I can quote both and as opposed to either /or. Show mutual respect. And we're solution focused when identifying a barrier or a systemic problem. We offer ideas for potential solutions as well as to inspire progress and creativity. And we make the best effort to attend all committee meetings. When attendance isn't possible, from the SURSAC administrator, Michelle Martinez. I think we all have her email. And language and terms, use people first language. An example of that is person experiencing homelessness rather than homeless person. Use the term substance use rather than substance abuse, which is stigmatizing. Avoid using the term addict. Person first language alternative, person with substance use disorder. When someone forgets to use these terms, assume that their intent is still good and be gentle with reminders to use agreed upon language. The chat guidelines, if attendees have questions or comments that arise during the meeting, for example, how many regions have Recovery Navigator Programs, the chat function can be used to submit those. If you are a Healthcare Authority program team member or other subject matter expert with direct knowledge that can answer someone's question, it is appropriate to provide a response in the chat. Questions and follow-up. Unanswered questions or other follow-up related to Healthcare Authority programs will be addressed with internal HCA meetings in between SURSAC meetings and communicated to SURSAC members during the previous meeting recap portion of the agenda or within a follow-up summary document. Virtual environment. Type complex questions or ideas into the chat so we can pull those out later. Use the raise hand function when someone else is speaking to indicate you would like to speak next. When multiple hands are up, wait for the discussion facilitator to call your name before speaking. Video is not required, although it is encouraged and helpful in facilitating conversation. Decision-making procedures and final plan recommendations. Decision-making is based on general consensus. If or when a vote is needed to move a decision forward, each member has a single vote. For those who have designated alternatives, the alternate may submit a vote in the absence of the primary committee member. Committee members must be present at decision-making meetings in order to use their vote. All decisions will be submitted as recommendations to the Healthcare Authority for inclusion in the SURSA plan. If HCA determines any of the advisory committee's recommendations are not feasible to adopt and implement, the HCA will communicate that back to the committee. Recommendations that arise during the committee meetings will be reviewed and processed internally by the Substance Use Recovery Services Plan team at HCA and categorized into the following: outside scope of committee objectives, not viable, with explanation, already being included in the plan or elsewhere implemented within state programs. Topic for further committee discussion to sort out details. Use of delegates. When a committee member is absent, they can ask anyone of their choice to attend the meeting as a member of the public who can report back to the committee member. Such delegates will be able to provide input at the end of the meeting as part of public feedback, but will not have the same main discussion and voting privileges as the committee members. State legislator alternates are members of the committee per ESB section 1.2.
Hey, Hunter, He did a fantastic job. That was a lot to get through, and we'll find our way to, you know, as we go through month to month, find the ways of, you know, highlighting those things and such. But first out of the gate to kind of bring us back there, it's been a few months since we went through that. And I really appreciate you agreeing to lead us in that charge. So really good job.
Thanks, for sure. It was my pleasure.
Yep. I also want to mind my manners here a little bit. I know we may have some new people, not only on the committee, but joining us as this is an open meeting. And I'm not sure I introduced myself. So I'm Michael Langer, Deputy Director with the Division of Behavioral Health and Recovery within the Healthcare Authority and Chair of the SURSAC Committee. So if I haven't met you yet, welcome. I very much look forward to the day when we can meet in person. We do have people coming back to the office now, but our office is not open to the public other than the main lobby. So hopefully one day we will get those conference rooms opened and be able to see each other in person. I think it would go a long way in our team development and committee development and just get to know each other a little bit better. So for now, we're virtual and we'll do the best we can. And Hunter, that was a great way to start the meeting also. Thank you. Let me just pause for a moment and see if there's any questions before we move on. I know we've been talking here a bit. Okay, I don't see anything up right now. I'll turn it back over to Michelle, and I think she's going to do a little bit of our SURSAC progress to date recap. And as we thought about these first few months and doing some orientation and getting some structure to ourselves, we also are making some progress, and it's hard to see that sometimes. So Michelle is going to walk us through a bit of a PowerPoint here and let us know where we are so far and then where we need to go. So Michelle.
Yeah, thank you, Michael. And I just want to welcome Senator Dingra, Senator Braun, and Rep. Taylor, who were able to join us in the past few minutes. So yeah, I want to just do a bit of a recap for where we're at with the plan so everyone's on the same page and we can acknowledge all of the work that's been done and what we have ahead of us. So here's a few, for those that haven't had a chance to dive into the bill very deeply, I want to just cover some of the bill language about the plan. So section 1.1 outlines the relationship between HCA and SURSAC. So the authority, HCA, in collaboration with the Substance Use Recovery Services Advisory Committee, SURSAC, shall establish a substance use recovery services plan. The purpose is to implement measures to assist persons with substance use disorder in accessing outreach, treatment, and recovery support services that are low barrier, person-centered, informed by people with lived experience, and culturally and linguistically appropriate. The plan must articulate the manner in which continual, rapid, and widespread access to a comprehensive continuum of care will be provided to all persons with substance use disorder. 1.2a says that HCA shall establish the SURSAC to collaborate with the authority in the development and implementation of the plan. And then there's a section that explains how the members of the committee were selected and chosen. And then 1.2b says that the advisory committee may create subcommittees with expanded participation. 1.4 says that the plan and related rules must give due consideration to persons with co-occurring SUD and mental health conditions and the needs of youth, include the substance use outreach, treatment, and recovery services outlined in sections 2 through 4 of the bill, which must be available in or accessible by all jurisdictions, and ensure that services are equitably distributed across urban and rural settings. Also, in developing the plan, the authority shall align the components of this plan with previous and ongoing studies, plans, and reports, including the Washington State Opioid and Overdose Response Plan, published by the authority, the Roadmap to Recovery Planning Grant Strategy, also being developed by the authority, and plans associated with federal block grants, and coordinate its work with the efforts of the Blue Ribbon Commission on the intersection of the criminal justice and behavioral health crisis systems and the Crisis Response Improvement Strategy Committee, also established in HB 1477. So there's a lot of coordination happening as well as part of this plan. So section 1.3, parts A through N, really give explicit elements that need to be part of the plan or considered as part of the plan. And so those are the elements that we've been focusing on during the meetings. The way that we've planned this out and structured this is that the first 3 months are very much focused on information gathering and trying to get a picture of the current situation. Starting this month, April, we're going into the formulating phase, where we're really going to be thinking about frameworks and strategies for creating solutions. And then beginning in July, working on solidifying recommendations to formally go into the plan. October is when final plan submissions need to be completed from the committee to HCA so that we have a couple months to turn it over and prepare it for submission to the legislature in December. And so I just want to review month to month what we've already covered and how it, the elements from that section A through N and 1.3 have what we've come up with so far in the meetings. So in January, we worked on parts A and C, the points of intersection that people with substance use disorder have with the healthcare, behavioral health, criminal, civil, legal, and child welfare systems, as well as the other locations with in which people with untreated substance use disorder congregate, including homeless encampments, motels, and casinos. And then part C, also the current regional capacity for SUD assessments. And the committee feedback, if you'll recall, we sent out a survey prior to the meeting to start that conversation. 7 committee members responded to that survey. And some of the common themes that came out of the survey, as well as the conversation, were that harm reduction can be a hard sell, including MOUDs or safe consumption sites, syringe service programs, and that there are difficulties surrounding outreach and communication to the communities, as well as policy hurdles. Also in January, we talked about Part D, the barriers to accessing existing behavioral health system and recovery support services. And I'll just quickly go through the committee feedback as a refresher. So one of the big challenges in Walla Walla is the lack of medically assisted detox. There's a disconnect between the types of staff required to medically manage withdrawal according to WAC requirements for opioid treatment programs. Many pregnant and parenting people are afraid of engaging with recovery services, even in resource-rich areas, to get their needs met. There are a lot of hurdles for people in Oxford housing. Committee recommended more treatment sites and recovery houses that allow children in them. When a person is ready for recovery services, it can be an issue that the appointment is often several weeks away, so that window of readiness can be missed. When a person seeking recovery is met with judgment from staff, that's another barrier. There are a lot of resources for parents who have custody of the children, but getting insurance, housing, and legal advocacy is harder for non-custodial parents. And then not sure where to find funding for outreach services, especially when there's no charge for peer support services. So these are some of the highlights. It's not fully comprehensive, but just to give, a reminder and idea of what we already have discussed and covered. And then in February, we talked about Part B, new community-based care access points, including crisis stabilization services and the safe station model with fire departments. Committee feedback included that we should expand crisis management and withdrawal management in rural areas such as Walla Walla, provide at-home client-administered withdrawal services, offer peer respite for SUD, expand medically assisted withdrawal management, expand youth-friendly detox services to rural areas that don't have them, expand inpatient treatment capacity, use social determinants of health as a measure of success, expand youth housing options in rural areas, expand substance use crisis management services for youth and adults, and offer a next step for people as soon as they get out of treatment. And based on that meeting in February, it seemed evident that we would need to create specific subcommittees to continue conversations. And the first one that we created was the Recovery Support Services Subcommittee, which we talked about in March. And so March, we covered Part K. We talked about the sequential intercept model and some other models, including LEAD, the Trilogy Recovery Community, Housing First, Just Care, and the Vital Program. And feedback also included the creation of a subcommittee to start work on data and on the other plan objectives. So then we talked about Part M, recommendations regarding the data collection in these other pieces of data that we need to talk about. So we're going to continue the data conversation today. But again, just wanted to cover those pieces that we've already discussed and summarize kind of where we are. So in terms of the feedback that we've collected, we have covered parts A, B, C, D, and K. And we have M scheduled for today, part I is scheduled for May, and then depending on where we go with the subcommittees, E, F, G, I, L, N, and maybe continued discussions for the parts A, B, C, D, K as well can occur within subcommittees, and we can flesh out that bit of the plan together a bit more. So everyone has access to the full bill as an attachment in the meeting, in case you're not familiar with these different sections and parts. And if you want to take a look at the month-to-month work plan and how the different pieces fit into different subcommittees, there's another document attached in the meeting, the SURSAC Work Plan 2022, that you can take a look at. But I figured slides would be easier than going over a document for the meeting. Okay, any questions about any of that so far? All right, I'm not seeing hands up, so I'll assume that's, oh, okay. Sorry, go ahead, Caleb.
Sorry, technology. So, good morning. As we talked about this, sort of looking at the state opioid response work plan, I really appreciate the framework you've put out there. Now seeing this deadline of October, not December 1, which I understand, this seems like an absolutely massive amount of work to get done in 6 months. And I see that we might have discussed things, but I don't see what the action or decisions have actually been. And I find it difficult to imagine how we can get where we need to in 6 months. I just don't see the work. I don't see the work happening. It might be happening, but I don't see it. And from what I've heard from other committee members, they're not seeing it either, at least the handful that I've spoken with. So it would be very helpful to see a more detailed, articulated plan about, you know, what are the decision points? What are the milestones? What are the intermediate outcomes that we're aiming at? Because it's just a ton of work to do. And, you know, 2 hours once a month is obviously, we can't do any work in these meetings, right? These meetings can't be actual meaningful working meetings. Maybe they're report back meetings where work's happening in the interim. But at the last meeting, I had asked, you know, to use this and communicate in the interim, and we didn't get any more communication. So from my perspective, there's probably been work done in the last month, but I don't know what it was. And to my knowledge, the committee hasn't been involved in it. So can you speak a little bit more about the process? Because I'm still not getting how the committee is going to be involved in the work, because we can't do work in 2 hours a month. And it's been 3 months and we haven't had subcommittees yet. So I'm concerned about how we're going to get this work done.
Yeah, so great question. So that's outlined in a bit more detail in the work plan. That's the attachment, but I'll just summarize, and this is next on the agenda to discuss as well. So for the subcommittees, we're dividing work among 4 subcommittees. So we've got the recovery support services, and then we'll have engagement, outreach, diversion, and then we'll have treatment and data. And so the elements, the deep dive discussions that I think you're talking about here that need to happen to create real, you know, fleshed out recommendations will occur in the subcommittees, and then the subcommittees will use these primary meetings to report back those recommendations to primary SURSAC for discussion and final voting, final decision making, And that's how we get the ideas that go ultimately into the plan, or the final recommendations from the committee to be considered for the plan. So so that's we're dividing and conquering those elements through the subcommittees, and I hope that makes sense. And we'll decide what pieces specifically go into the remaining monthly meetings for discussion as we discuss the subcommittees later today. Does that answer your question, Caleb? All right, go ahead, Brandy.
Well, it's similar to Caleb. So I put in the chat box, when do we get invitations to the subcommittees? Because I haven't seen anything to join any subcommittees yet, even though it's been talked about. And there was a lot of things in the presentation you just gave that we talked about, but I was wondering if decisions have been made, like, for instance, like harm reduction being a hard sell. Like, I know that was somebody's opinion, but have we talked about that as an actual thing? Are my two questions.
Yeah, so to answer that second one first, the information gathering phase is not, none of those ideas or suggestions that have come up are going to be, no decisions have been made about what's going into the plan specifically. Those conversations still need to be had. So we'll loop back to those, but those are all part of the divide and conquer through the subcommittees, which helps me answer your first question. The only subcommittee that's been established so far that everyone was invited to at the last meeting in March is the Recovery Support Services subcommittee. So if you didn't get an invitation to that or missed that, just let us know in the chat if you want to participate in that, and we'll send you the invites and get you connected to that subcommittee. But the other ones are ones that we're introducing today, and we'll at the next agenda point, we'll get your feedback about how, who to include in those subcommittees and how you want to, do leadership and share them, and together decide, what the next steps are for those subcommittees. So you haven't missed anything there. Okay, great. Sorry,
Michelle,
thank you. Yeah, go ahead, Michael.
A little bit of feedback here. Thank you for the questions, and thank you for the level setting of where we are in April, early April. Are we losing sleep? I'm not sure we're losing sleep, but we may be tossing and turning a bit, given the amount of work and the timeline that we have. We do know it's a lot of work to do. We do know we want to hear from you and get the feedback from the different perspectives, and then get the plan drafted out. What I'm taking from this is, Michelle, maybe one of our takeaways is, even if it's a one-pager, for each of the sections, how do we draft that one page once we get the feedback to present it back here? So if we have a consistent format that we can show the broader committee, that might be a way for people to feel like they're getting that detail a little bit more. And to Caleb's point about engaging between meetings, that this will be happening. It started last week or week before last, and it will continue now. There'll be a lot of work between meetings that we need your feedback on. So thank you for the questions. I also want to give the committee just a little bit of feedback I received outside of the meeting, because I think it will be helpful. It's not necessarily called out in the legislation, but we do know our child welfare system is impacted significantly with substance use disorder challenges. And I know they've been in on these meetings. The Department of Children, Youth, and Family have been in on the meetings, listening into this conversation. They're very interested in doing more. They're very interested in having services available for the populations and families they serve. So I say that now in this part of the agenda. So as we consider what's in the legislation around youth and co-occurring and so on and so forth, if we can kind of keep in our mindset, how do we best serve those families that are engaged in the system through DCYF also, that would be, I know, of interest to them and probably to all of us. But we can talk about that more going forward. But I wanted to bring that in today and share that perspective that I've had some outreach on. So with that being said, And thank you for the recap, Michelle. One of the things we started to do at the last meeting, and more questions arose, and I think that we were able to articulate answers for. And as we debrief, we recognized, well, we have many more answers than we shared. So I'm going to ask Tony Walton and Suzanne Straub to talk a few minutes about, I think we're just about on time, just a minute or two over, talk a bit about data collection for the Recovery Navigator program. Now, this is one program within Blake, and it's an important one, and it's an exciting one because it's new services on the ground throughout the state, or at least in every county. But, you know, this will be one component. The plan that we create will be about outreach and engagement and diversion and treatment and recovery and all of that. And so there's a lot more to do than this. However, I know this is a key pillar of the Blake bill, and it's also very much interest of this committee. So we've asked Tony and Suzanne to come in, give us a little bit more detail on what we are collecting with the Recovery Navigator program and what the future might entail. So Tony, I think you're going to kick it off, and then we'll have Suzanne available for questions as well. So Tony Walton.
Yeah, good morning, everybody, and happy Monday. I was asked to come in and talk about the Recovery Navigator program, data collection, and reporting process. When the bill passed last year, kind of tried to, hit the ground running and start immediately with developing the uniform program standards ad hoc committee, start thinking about metrics we wanted to look at, and really start having those conversations. So this is the result of, I guess months of conversations, but also understanding the fact that in the future, once the committee was stood up, which would take a little bit longer, that we would, reach out to the committee and have this sort of feedback process. So let me just go ahead and get started. Oh, quick introduction. My name is Tony Walton. I'm the Senior Project Manager for Division of Behavioral Health and Recovery, overseeing implementation of and grow Senate Bill 5476. So involved with Recovery Navigator Program, host, homeless outreach stabilization transition, clubhouse peer-run organizations, medications for opioid use disorder in city, county, and tribal jails, trying to support Michelle with the SURSAC committee, and doing anything I can to help support the abundance of programs and initiatives going forward. So it's been really fun, a lot of work, but also good work, important work. So I wanted to start with just kind of covering or summarizing what the role or the intersection between the SURSAC committee and the Recovery Navigator program are. As you'll see in the first bullet point, that the SURSAC plan must consider the design of Recovery Navigator programs, including reporting requirements by the Behavioral Health Administrative Service Organizations, or the BHASOs, to monitor the effectiveness of the programs and recommendations for program improvement. So that's one thing we'll be talking about today. And then also the committee input must include each Recovery Navigator program must submit quarterly reports to the authority with information identified by the authority and the SURSAC committee. And the reports must be provided to the SURSAC committee for discussion at meetings following the submission of the reports. So just a little bit of background. We didn't start from zero with this. Luckily, in 2019, under 5380 and House Bill 1767, the Healthcare Authority was directed by the legislature to do a lead pilot program as part of the opioid response bill, and also coordinate with WASPIC, or the Washington Association of Sheriffs and Police Chiefs, and the Criminal Justice Training Commission, CJTC, in implementing rest and jail alternative program. So we've been having conversations related to pre-arrest diversion since 2019. So we basically took the metrics, the data points that we were looking at for the lead pilot program and the arrest and jail alternative program, and looked at those within the Recovery Navigator model within that same framework, considering what metrics we would want to identify and consider for future program evaluation. And then once Jen Weinman and Suzanne Straub were hired and onboarded and joined the team, we had conversations with the lead National Support Bureau about what that framework would look like, and they've helped develop a draft evaluation plan to include metrics such as the one I'm presenting on the screen, as well as considering anything else in addition to those which might be helpful in determining the long-term outcomes of the program, how its impact on the community, and also most importantly the impact on the individual being served by the Recovery Navigator program. So I took the time to just kind of pull some of those evaluation metrics that we have included in the draft evaluation plan with our TA providers and presented those on the screen. So in looking at the following data points, or the actual data that we'll be collecting, consider some of these. And also please let us know if you have any recommendations about additional metrics to include. This isn't exhaustive. It'd take a long time to go through an entire evaluation plan. But I thought this would be helpful in terms of kind of trying to understand what we are considering within the guidance provided by the subject matter experts, and also how it relates to these other programs, the lead pilot expansion under 5380 and the rest in jail alternative program, and how they can coordinate together, because they are all so similar. So I'm going to go ahead and present some of the data that we're currently collecting through the BHASOs. And while looking at those data, please consider the following. What additional data would you like included for review in quarterly reports? And are there any additional data which would be included as part of the participant level data collection efforts? There we go. So first is the referral and outreach data. So the data collection has kind of broken down into two separate pots. You have the data that's collected upon referral and outreach when the program participant or person being referred is initially contacted. And then you have for actual participants who are receiving the intensive case management data collected at here, I'll just show it right now. So you have the case management or tracking encounters, and then you have the referral and outreach data, which is collected upon referral. So I want to point out that the fields that we use, and I think Michelle sent out a Word document that actually broke these down. So you can see the actual options that we're collecting for race, ethnicity, gender, source of income, housing. Those are all aligned with the behavioral health data system guide. So sometimes we're trying to align systems the best we can, understanding that just like with treatment, there's not a one size fits all approach to this, but at the same time, if we're able to align with our current data collection systems, that has benefit in the long term. So basic demographic information is currently being collected: first name, last name, date of birth, race, ethnicity, gender, sexual orientation, source of income, and housing status. And then also more specific information about the actual referral itself. So the date and time of referral. The legislation directs that at some point this is a 24/7 response program. So being to know what date, the time of day, are the referrals coming in on Saturdays? Are they coming in at 2 a.m. in the morning? Having that data will help determine whether or not we're meeting the intent of the legislation. The referral response time. In addition, how long is it taking for Recovery Navigator Program staff to respond to a referral from the community, or I should turn off the chat because I'm getting distracted. We'll take all questions, answer questions at the end. Referral response time, like how long is it taking to actually have individuals deployed to the community responding to the referral from community or law enforcement? And then with that, the referral source, where are the referrals coming from? The Navigator program language was really broad, like obviously a focus on law enforcement because this came out of the State versus Blake decision, but also having, this be a referral option for individuals in the community, businesses, friends, family members of loved ones who they feel might benefit from the program. Um, really tried to be really broad with where these referrals can come from. The referral reason, the location. I think this is really important. Like, where in a year from now, after these programs have been providing services for a year, are all the referrals coming from urban centers? Like, are we meeting the our law enforcement in rural areas? Do they feel comfortable making these referrals? Are we receiving referrals from OMAC and other areas? Are we meeting the geographical catchment requirement? Screening outcome, case management level, basically, what did that initial interaction look like? So you have a referral that comes in, an individual outreach coordinator meets with that person. What happened at that initial interaction? Is that person, um, uh, did they screen for anything? Did they receive any services like direct client services? And then ultimately, were they enrolled in the program? Are they interested in ongoing case management? Did they, just ask for a list of housing resources? What did that look like? If they are interested in ongoing case management and technically become a program participant, then we would capture individual encounters or case management events for that person to understand the extent of case management that they're receiving, the types of services they're being referred to, um, and how many times, the frequency. Frequency, so kind of the uh, the type of services, the amount of services, and the breadth of services. Hold on one second. Had to get a drink of water. When I start rambling like that, just, yeah, sorry about that. Okay, so for case management data, again, we have the identifiers. We're trying to, if the person has a provider one ID, go with that so that we can link up at the healthcare authority side with Medicaid data. If they don't, then a agency developed Recovery Navigator Program client ID would be used. And then attached to that client ID or provider one ID would be the date of the case management event, case management phase, engagement level. Essentially, is it light case management? Is this, somebody who basically indicated, yeah, I just need a house, like I have a lot of things going. Yeah, I might be using substances, but really I just want a safe place to live, like, and once that person gets help, once they are helped by the case manager and they find housing, then, that might be it. That might be the extent of the immediate social determinant of health that they're looking at. Or is it more intensive? Like, not only that, but they also have co-occurring disorder that's never been treated. They are, kind of separated from family members, and maybe even have a case with Department of Children, Youth, and Family, and what that might look like. Uh, is the person participating in contingency management? Basically, a straight yes or no. We want to be able to track that because there's reference to contingency management throughout the bill. There's funding for contingency management for the SOAR opioid treatment networks. Was this person engaged by outreach follow-up? Did they come in for case management? Were they approached for case management and then for a subsequent appointment they didn't show up? So that's an opportunity where the outreach coordinator or outreach workers can then go try to find them or follow up with them in the community or by phone. Um, which referral to services are made? Um, Linkages to care, so like a referral and actually helping somebody get to an appointment are two different things, like, so that's why those are separated. Like, a referral was either made or a warm handoff was made, and the staff actually helped drive or find transportation for that person to get to their appointment. And then basic release of information consent signed, and then also whether or not an individualized service plan was created. These both align with, a lot of these data that are being collected align with both the lead core principles and also the uniform program standards that were developed. And just a reminder, the uniform program standards can be found on the State versus Blake webpage for the Healthcare Authority if anybody is interested for more of the background regarding that. So bringing it back to the committee for feedback and input, which additional data would you like to be included for review and quarterly reports? Are there any additional data which should be included as part of the participant level data collection efforts? And at this point, I would ask for those questions. I can start with the ones in the chat, but also Suzanne, hopefully you're around to answer some of the more current questions that I might not have the answer to, because I kind of helped get the ball rolling, and then really Suzanne and Jen have been instrumental in keeping this going forward and have done a lot more of the operationalizing. So
Tony, I'm just going to, as a facilitator here today, check our time a little bit. We're at 9:53. And so I think we can adjust a bit and take a few questions. And then I think we need to ask, how are we going to collect feedback from you? If many of you have feedback as to what else we can collect, maybe we can send that out and you can send it back in, then we can share it back, your feedback. But let's take a few minutes. I just know that there's so much good work here happening that we could probably take the next hour talking about it. And I'm not sure we have an hour. So I know we don't, but I see some hands up, so go for it.
Sorry, it's hard to unmute. I just had a question. One thing I'm always concerned about since I've been able to do lead the last couple of years is how are we going to manage for racial equity? I'm going to be really interested in knowing if now that police across the state are going to be able to refer people to services, are they only going to be referring young white men to services? How are we going to collect the data to see like who they're pulling over? Are they make sure we have that racial equity lens? Are people of color actually being referred to more services, or just getting pulled over, arrested, or whatnot?
Yeah, no, Brandy, that's a great point, and that's definitely something that we've been talking about. Obviously, if we're not collecting that contact data, law enforcement contact data, but we're only looking at who are being referred, we don't know that, right? We're not able to identify whether or not this is an equitably referred to program by law enforcement. So that would require kind of cross-analyzing this, or looking at who's being referred compared to who's being arrested, right? Looking at the arrest data that we have access to. Also, WASPIC collects NIBRs. I forget what the acronym stands for, but it's basically law enforcement contact data. And maybe if there's somebody with law enforcement that can speak more to that, that might be helpful. But those data are out there, and it's just a matter of, once we have enough data of those being referred, looking at those not being referred. Like, okay, so we know this is the makeup of people that are being arrested for unlawful possession of controlled substance, and this is the people or cases filed, misdemeanors, so in the city or county level district courts, and doing that sort of analysis. And luckily we have our partners at RDA, or Research and Data Analysis, who have access to a lot of that information to help us with that. As both a evaluation metric, but also as an ongoing process improvement. Oh, Alex, thank you so much. NIBRS, the National Incident Based Reporting System. So I guess I would maybe Michelle, thinking about how much time, I think, are we out of time? Like, do you want me to address some of these questions in the chat, or do you want to lay out a feedback process for the committee to get any feedback? I guess I would defer to you on that.
Yeah, so we are a bit over time. So I will follow up in an email around this to gather some feedback. since this, yeah, I guess we've run out of time for this conversation about what to include in the reports, and there's probably folks that want to provide input need a bit more time to sit with the data first and this information. So I'll send an email out very shortly following this meeting so that you can take a look more closely and provide some feedback. Yeah, Tony, let's see. I guess we'll figure out how to communicate that back to the committee so that you all know what is being done with, your recommendations and suggestions around this piece.
Yeah. Michelle, if I can interject for just a moment, I do see Hallie had a few questions here that are more about the process. And so I think if we took a moment, because I think we want to send out the data information and get your feedback to that, right? So then we can report back to you all. But some of the process things I think we can answer here on the fly, that these resources went out to the BHASOs, and then they did their choosing of subcontractors for each of the counties. So it sounded like there was interest of who are the contractors. And I think we're pretty close to be able to give you that report. Tony or somebody put in already, or maybe Michelle did, that we've got North Sound and King, I think, that are maybe waiting a little bit longer to name or to get their folks in the community. But it's really, really close. It won't be too much longer. But does that make sense? Tony and Suzanne, particularly you're on here too. Not too much longer before we can give a full state report of who the contractors are.
Hi, Michael, this is Suzanne. Yeah, we should know in the next week or two who King County has contracted with, and same for North Sound.
Okay. All right. Thank you. And Hallie, in terms of how the processes work for each region, we don't read, they all have their process. We don't tell them how they have to do that. And so maybe once we get you the list and if there's more specific questions about process, we can follow up on those. Okay. Anything else that's more general about process here before we move on? Okay. We will obviously, thank you guys for sharing this. Hopefully for committee members, you feel like you have a little bit more detail as to what's being collected. I think there was a question about when, so maybe we can answer that one quickly before we move on as well. When are the regions, providers more specifically, when are they being asked to report this information? So Suzanne, do you want to address that?
Sure. So they have been collecting data since January, and we recreated the workbook tool. So the one that Tony just went over with you guys, we redid that, revamped it to include some of our quarterly report questions. So they'll be turning that in monthly. This new tool that Tony was just sharing with you guys, that started Friday. So they'll start using that tool Friday, new quarter, new report. So does that answer the question?
Hopefully. I mean, the answer is they're collecting the information now. It's how we're getting it and compiling it is ever evolving. And quite honestly, the first grouping of information we got in was pretty complex to figure out how to compile it well. Many, many, many pages, hundreds and hundreds of pages of information came in. And so we had to go back to the drawing board a bit, and because there wasn't, we did the standards for the Recovery Navigator. We got the resources out in contract, making sure that folks get their people trained before they start providing services. But having a data collection system at the go, ready to go immediately, wasn't there. We've had to create it. And so we're learning along the way. As soon as we get this in a place where you can make heads or tails out of it in terms of reviewing it, we will get it to you all as a committee. So that's about as sophisticated as I could put a process that's sort of in its infancy and going forward. So anyway, thank you. We will get you these questions out with the data again, so that if you have feedback, we'll give you a timeline so that you can get your feedback into us, and then we can make adjustments going forward. So thank you, Tony. Thank you, Suzanne. Thank you, Michelle. And more importantly, thanks committee members for asking us to slow down a bit and give you a little bit more detail today. So I'm going to take a breath here, and I think we are ready to talk about subcommittees. And so I will kick this off for a moment just to talk about our response to some of the feedback we received both during the meeting last month and then post-meeting. Caleb, one of our committee members here, sent out a request and say, hey, we're here. We want to work. Let us work, please. Engage us. And so this is our plan in response to that. And we do have 4 committees. The one committee we had spoken to before about needing to get information going to be able to be responsive to the law is around outreach and engagement. And we encourage you to give us feedback on what's currently going on with outreach and engagement, what you would like to see happen with outreach and engagement. Senator Dingra initially in the first meeting, I think, said, challenge yourselves, right? Challenge ourselves. Let's not just look in our backyard, but let's look in our region. Let's look in our state. Let's look at nationally or globally about what we might do differently. So we want that committee to do that around outreach and engagement and then bring those recommendations forward. We are including in that committee diversion. It was asked for at the last meeting last month. We need more time with diversion. We don't want to go too quickly with it, and it needs space to have a conversation. We put it in with outreach and engagement. We're hoping that will work as a place to have that conversation. A part of this is matching staff capacity with committee interests and such. And so we certainly hope that will work itself out. I'll have Michelle go through these in a minute. I'm just giving you kind of the highlight here. We talk about treatment and how important treatment is. And so we do have a committee set up to address the plans forward in our state around SUD treatment. Recovery support services, we have spoken about that. A lot of talk about housing, but certainly education and employment and transportation and childcare and whole host of things around recovery supports, including the integration of peers and how important that is to support recovery. So we have a committee with that. And then finally, we have the data committee. And you saw, again, I can't stress how important recovery navigators are to get out there in the field. And we're just thrilled that we have outreach and case managers and such across our state. But there's much more. There's much more beyond that. And just that one program, you can see we could probably spend 2 hours just talking about the data that Tony and Suzanne just went over around Recovery Navigator Program. So we heard the cry from the last meeting, or the ask more appropriately. And so we are going to set up a data committee because the data should be looked at from not only project by project, but also as a plan. If we're going to have a plan going forward for outreach, engagement, diversion, treatment, and recovery, how are we going to tell whether or not we're making a difference? Not only about plan implementation, but more importantly, the impacts of the residents of our state. So we do want to set up that committee, and that would be the 4th committee. We believe we have the staff support to do all 4. We will be asking for volunteers in terms of not only serving on the committee, but also co-chairing those committees with our staff. So Michelle, I think that's what you wanted me to do as part of this kickoff, and I will turn it back over to you and let you go through the committees, if that makes sense at this point, or if there's any questions before I do that. Okay, I don't believe I see hands up here this morning, still morning. So Michelle, I'll turn it over to you and let you go through the committees. You're on mute, Michelle, or else I'm not hearing you maybe.
No, I was on mute. Sorry about that. So I'll be sending out an email for each of you to be able to sign up essentially for each subcommittee that you want to be a part of. And then from there we can, you know, figure out the cadence of the meetings and when, days, times, all of that, and how to nominate co-chairs and continue with that. But right now, I just want to go over what each subcommittee is charged with doing, what recommendations they're expected to provide at the larger monthly SURSAC meetings, so that you know exactly what the charge would be for each subcommittee that you may be a part of. So the first one we'll go over is the Outreach, Engagement, and Diversion Subcommittee. So these are all, you know, those elements, those letters pulled straight from the bill related to this area, this community engagement and diversion piece. So recommendations regarding the appropriate criminal legal response, if any, to possession of controlled substances, and then recommendations for designing a mechanism of referral for people with SUD or problematic behaviors resulting from SUD into the Recovery Navigator Program. And for some of these, there's going to be a bit of cross coordination needed between the subcommittees. So, oh, sorry, that is this committee. That must have been. All right. And then section 1.3M is data related. And so this is where there may be coordination with the data subcommittee, but it's diversion related as well. So recommendations regarding how to collect and report data that capture the following. So the number of people engaged by law enforcement and prosecutors related to drug possession, and then including all of this demographic data so that we can do the work of seeing, you know, if there's disproportionate referrals to recovery navigators or into, you know, charges and into custody across these different levels, as well as the number and rate of people who receive services and what type of services they receive, the number and rate of people who are charged with simple possession and who are charged and taken into custody. So, so there's that piece, and then also the piece in section 1.4 about the rapid response models to initiate services on demand 24/7. So all these pieces related to community engagement, outreach, and diversion are included in this committee here. And then a note here from section 1.5 that this also should be considering and coordinating its work with the efforts of the Blue Ribbon Commission and the CRIS work, so Crisis Response Improvement Strategy Committee, established in 1477. All right, and then the Treatment Subcommittee will be working on establishing or looking at current regional capacity for substance use disorder assessments, including capacity for people with co-occurring substance use disorders and mental health conditions, along each of the American Society of Addiction Medicine levels of care, which are outlined here, and then recommendations for evidence-based, research-based, and promising treatment services appropriate for the target populations, and then also recommendations to leverage existing systems of care for treating substance use disorder and improving coordination between all of these different organizations, agencies, and systems. And then also recommendations for designing a mechanism to refer people with SUD or problematic behaviors into the Recovery Navigator Program. So essentially the Outreach and Engagement Subcommittee and this one will be working on that piece so that there's both the referral end and the receiving end that are on the same page about how that referral mechanism is going to function. All right, and then this one, Recovery Support Services Subcommittee. So this one is focused on the recommendations related to, as Michael was saying, recovery housing, supportive housing, employment education pathways, family education, childcare assistance, social connectedness, and also making sure that existing recovery services and recovery support services meet these different needs as well. So there's a whole lot to consider here. And again, this one's up and running if you would like to join. And I know I saw in the chat several people did say that they want the meeting invites and to be included in that. Just let me know in the chat or email me in response to the email I'll be sending out to let me know that you want to be part of this one, and we'll get you connected with that subcommittee. For the other subcommittees, they have yet to establish a cadence in a day and all of that. So depending on the members involved, we'll figure that out together. And then finally, the data subcommittee. So the only piece explicit about data in the bill is 1.3M, talking about the collection and reporting of data that identifies what we had talked about in the diversion piece about the number of people engaged in law enforcement, the number of people charged versus referred to recovery services, and making sure that the demographic data is included there so that we can look at disparities and equity as part of that process. And this piece will also begin that conversation today after we finish talking about the subcommittees themselves. Okay, any questions? And I'm not caught up with the chat, so I apologize. But any questions or responses, reactions to that subcommittee plan?
Can you just real quick say all the subcommittees real quick one out loud again? Just all 4?
Yeah, so engagement, outreach, diversion, treatment, recovery support services, and data. All right, go ahead, Hunter.
Hey there. So, how many chairs are open for each committee?
Yeah, great question. So we are going to have a co-chairs, one person from HCA and one SURSAC member to co-chair each subcommittee. If there are different ideas for how to handle that, we can discuss that as we move each subcommittee forward. But that's, yeah. All right, go ahead, Kevin.
Yeah, a couple meetings ago, there was someone from HCA or working on behalf of HCA collecting data, but it was more care related, where as the discussion, as I recall, went, they're working on collecting data from who the providers are in the communities so that they can pop up in whatever whatever program is developed on a computer internet interface, and a person can see what providers local to them. And I see it as being part of the section related to D under care. And we're dealing with M today, but under D, it seemed like it was care focused. And they said that their challenge at the time was related to the care providers not having individual addresses, but it was going back to the billing hubs. Now, I want to be part of a committee that helps deal with that sort of data collection as far as the obstacles to providing recovery. So if you guys could clarify how that kind of data is different than the type that was outlined in the data subcommittee.
Are you, Kevin, just to be clear, are you referring to the asset mapping tool? I think we went over that in February.
Yes.
Yes. Okay. So can you say real quick again, like, are you saying you want to be involved in data that is evaluating current situation, existing services?
Yeah, as it relates to providing care and as it relates to a potential barrier to providing care, because we're not getting the actual data of where these providers are located physically.
Right. So depending on whether you want to focus on recovery support services in that way or treatment services in that way, that would be under this regional capacity piece for one of the, so data elements can be and should be part of each of these committees when they're evaluating existing situation and where services are needed and gaps in that way. So I hope that that's clear that data work is not limited to the data subcommittee, but that's its own subcommittee because that's the only piece of these elements that explicitly calls for a data collection and reporting plan as it relates to the plan as a whole. If that makes sense.
Okay.
But if you want to focus on like current regional capacity evaluation, then that could be in the recovery support services subcommittee, or in the treatment one, or both.
That's what I needed. Thank you very much,
Okay.
Michelle.
Yeah.
If I could, Michelle, I know it's what we have 10:17 here, so I know we have to move along the agenda here at some point, but I do want to address, I think Caleb had put into the chat about, does this reinforce silos? We have to find a mechanism to divide the work up. Unless the committee wants to come in and we do 3 full days together or something, there's got to be a way of sort of chunking this up and then coming back to the larger committee for discussion. This is a way we thought we could get through the components that are called for in the legislation, understanding that I believe it's the interest of the authorizers, the bill sponsors who are here, and the administration to think creatively, to think outside the box a bit, and to really bring the best forward that we can think of in terms of how to best serve individuals and families and the communities they're living in that are facing substance use disorder challenges. So whereas we have these committees, there's nothing to say you can't be on more than one of them. There's nothing that says we can't bring forward creative solutions that may, in fact, take into consideration all 3 components into one program, right? And so please don't feel limited by the committee titles or something to that nature. We do have to get through the legislative pieces. It is important that we stay on time with that. But if there's a creative solution that really braids together outreach, treatment, recovery, outreach, recovery, just recovery, whatever that might be, don't hold back. Share it. If it doesn't fit perfectly in the committee you're on, share it anyway, and we'll find a way to bring that information forward to the larger group. So thank you for that. At this point then, Michelle, I think you're interested in 2 things. Members to please share if you're interested on these committees, either in the chat or when Michelle sends out the request after the meeting. Please let us know if you're interested in being a co-chair of the committee. We need to know that as well. And then let's see what else we have. There will be some other folks that will join the committees that have expertise in these areas and a lot of interest. And so if there's people that you want to suggest that we reach out to, let us know that as well. I hesitate, quite honestly, as a chair, getting the committees too large because they have to be functional. They have to have time to get deep into this stuff. But we'll start with an open concept here, and if we have to come back to you and say it's getting out of hand, we have too many people, we'll let you know. But you will be the priority as SURSAC committee members. So with that, anything else, Michelle, or any questions? Oh, I see a couple hands up. Everett, you had a question here, it looks like.
Hello, good morning, everyone, and thank you all for being here and letting me come in as a guest. I know you're pressed for time. I'm Everett Maroon. I'm the executive director of Blue Mountain Heart to Heart in Walla Walla. We are an AJA, Arrest and Jail Alternatives Lead Site co-manager, and we are a RNP contractor for Walla Walla and Columbia counties. I also sit on the lead TA committee, so advising folks around the different BH-ASO regions, and I run a low barrier program, and I do lots of harm reduction. At any rate, this is my whole life. So I just want to, offer an idea. I know nobody wants to be building train tracks, trying to meet in the middle between this committee and then the folks on the ground doing the work. So I think it would be, and I know you're all very busy people, but I think it would be very helpful for some coordination folks that are going to be on these committees where I know the work really does get done, to be sitting in on some of those BHASO calls with the folks who are doing the work on the ground. Possibly sit in on a PCG meeting in your region, or another region might even be better than your own region, and see how that work is really happening, see what issues are really coming up for people, because there's a danger here that you're going to come up with recommendations and ideas that will be too divorced from what's happening for folks who are doing the work. And so, and then everyone will have to try and tie those ends together. So we're still really pretty formative in my experience of what I'm seeing and talking with folks. PCGs are getting stood up. People are hiring and onboarding and talking about training, and we've gotten some great guidance from HCA and some great guidance, if I do say so myself, from the lead TA team. But I think there is more than one way to skin this cat, but there's certainly a lot of ways where we could just do it wrong and be very ineffective at the launch, and nobody wants that. So it's really, there are some things that have already been invented. WASPIC already has a pretty good EHR out there. And so I would love for people across the state to be talking about how do we leverage what is already available in that system for the folks in the RMP system, so we're not inventing 27 new software systems that won't talk to each other. Any rate, I'll leave it back to the rest of you, but those are just some of my concerns, that this will be too removed. Thank you.
Thank you, Everett. I have to watch myself too. I'm sorry, committee members. We have a couple, thank you. And we will take that under consideration for sure. So thank you, Everett. We have a couple committee members, I think, that have a comment, and then we probably need to move on. We're starting to fall behind a little bit here. So let's see. First up is Caleb. Was that it before? Caleb, you're okay. I'm seeing the wave. I maybe there's communication. Hallie, do you have a thought before we move on? Maybe it's me. It looks like Hallie might be.
Hallie, if you're trying to speak, you're muted.
There we go. My laptop was running out of battery. I had to quick put it on the docking station. Sorry about that.
That happens. Yep.
I don't have a good camera set up, so I had just unplugged my laptop to use it. So my concern is, first I want to thank Everett for jumping in. I have some really strong concerns. I'm feeling a little lost in regards to when this committee first started. It felt super exciting, like we're going to do some cutting edge stuff, really diving into doing something new. And as it's progressing, it feels like it's getting really fractured. The idea of these separate committees, I think, is a standard approach to problem solving and nothing new that's going to create change. I think that conversations that create change happen through strong collaboration and building on one idea that leads to another thought that leads to another thought that creates a whole holistic solution. And these individualized committees are not a holistic approach at all. They're doing things in the same old way and expecting a new solution. So I really want to encourage you all to look at an alternative. I'm feeling like I'm going to be really, so when we first started, we said, be bold, speak out. I'm feeling like I'm kind of being herded through a cattle thing by the HCA right now. Like you already all had a plan. And now here I am going, what's my role in this plan? I no longer feel involved. I work on the ground and I'm learning to speak up about that too. I felt really shy about saying this is what I do and this is how I feel, but I'm working on the ground doing groundbreaking work. And my voice now feels super muted. So I just want to throw that out there in general. I don't know what you guys are looking for at this point. If you're just wanting us to applaud and approve what you're creating, or if you're really wanting something new from us.
Thank you, Hallie, for sharing. I will say it's probably a little bit of both, and this is why I'm going to say it's a little bit of both. The both part comes in that we have to be responsive to the legislation and create a plan that addresses the points that are called out in the legislation. So in one area, we're trying to create a process by which your voices can be heard in how those components of the legislation should be addressed. And so that does take some structure, and we are asking you to engage in the process and share your thoughts related to that. On the other side of the coin, I guess, if you want to put it that way, or however we should say it, is boldness and creativity and innovation is encouraged. So we can do more than what's called for in the legislation, but we have to do that part. So let us know what your creative ideas are. We tried to open up in the last couple meetings about things such as diversion or outreach, or what should creative treatment look like, or what does a recovery plan for the future really mean? What does that look like? And tried to pull it out in the larger groups, and we got some ideas, but we want to go deeper. We want to hear more about what your ideas are in order to be creative in those areas. So again, if it fits in the box, then let us know. If you have a creative idea, you're on the ground, you're working, and say, man, if the state would just do this, it would sure serve people a lot better. We do want to know that. But this was, the plan isn't written. It's only the framework of it that we have to start formulating in order to meet our timelines. So we still want we're very interested in what your thoughts are. And it looks like Senator Dinger is the sponsor of the bill. You're up next. Do you have a reaction or thoughts about what we ought to be doing, Senator?
Thank you. I just wanted to say, it's all of that. And I think all the comments made about making sure we're not in silos, making sure we're being creative, and making sure we have a work product that is required by the legislation. All of those are true. And I think that's the challenging part, is how do we do all of that work? And I also wanted to point out that we're not the only ones engaging in this work. They had mentioned coordination with the 988 team. That's a whole different process that's taking place with HCA and DOH, and what will a response to the 988 number look like? And that feeds into this work as well. And the Blue Ribbon Commission that was mentioned, that's an ongoing group that's going to be taking a look at things long term. So this is not a process that's done when the report is submitted, because there are lots of other groups, and the work's going to continue, and we're going to continue to tweak things and change them as needed. And a lot of the recommendations that come out of here are going to be new legislation for next session, and that's going to generate more work. So I just don't want people to think that a deadline means that all work is completed and we're not going to revisit it again. So this is frankly not a starting point, because there's been great work being done in the community, but it is a way of coming together to be deliberate and thoughtful about that work and discuss next steps. But there absolutely are next steps, and there absolutely are a lot of other people involved in lots of parts of this work as well.
Thank you. Appreciate the comments. And there is a lot of work for sure going on. And so, our challenge is, how do you bring that all into the fold and get the feedback and creativity going and get it written in time, right? So that's what we're attempting to do here. Hallie, I see your hand up. I'm not sure if it's still up or if you had a response to either my comments or Senator Dinger.
Hi, yes. First, I want to thank the senator for speaking. I appreciate the responses. I will say that my concerns are not alleviated. I'm curious, are we the only group of lived experience that's participating within this process, or these other groups that you're talking about, are they infused with people with lived experience as well? And is there a way, so in my experience, creative solutions happen based on the energy of the people coming together and really diving in deep. I'm going to propose, is there a way for us to come together as a group and physically together and have, Zoom going on for those that maybe aren't on the committee or that aren't able to get to that location, just because I really think that that's where strong work happens. I'm truly concerned. I feel like right now I can say anything and everything and it won't necessarily have any impact. That's how I'm feeling right now.
Okay, well, thank you for sharing how you're feeling, Hallie, for sure. I want to honor that. And I guess that's part of our challenge is to, have a process where people are feeling heard and feel respected and confident in what they say will be taken under consideration. So we'll really work to make that happen. In terms of coming together in person, at the onset of the meeting today, I mentioned that I am very much looking forward to when we can host in-person meetings. So we'll get back to you all about when we think that might be possible. And then Senator Dinger, I think you had a response.
Yes, I'm sorry. I know we're running short on time, but Hallie, I think you've raised extremely valid points. I'll say both the other groups have peer involvement as well. And I can tell you that in the 988 group, they actually created a peer subcommittee and just had an open invitation to anyone who would like to participate. And I know they meet monthly and they just meet and discuss things. And I don't know what all they discuss, but they bring it back to the larger group on what their recommendations are. So I think if there are any creative ideas on how people feel they need to be involved or participate, I, for one, definitely want to make sure that those ideas are heard and those processes that we pay attention to those processes. So 988 definitely has a very clear component of peers, how they engage, and they've actually gone and done their own subcommittee because they felt they needed space just for themselves to have those conversations and bring it back to the group. The Blue Ribbon Commission hasn't started yet, but they will have peer involvement as well.
Okay, thank you. I think there's a couple more responses in the chat as well. So, folks, we probably should move on now, but thank you for heeding the request to speak up when something is on your mind. I really do appreciate that. And up next, we have, in terms of recommendations, methods and sources of data collection for section 1.3. Michelle, I know we're at about 10:35. Do you want to go ahead and introduce this concept here, and then we'll need to determine whether we do this at the data committee, or what we want to do with this one, and then we have public comment time as well. But I want to kick it to you, and this is share what was being expected, and then what the ask is.
Yeah, so as we've talked about a few times so far in the meeting, this section 1.3.m is really the explicit data ask in the plan. And we just wanted to start this conversation at the meeting as a whole, in part to provide some guidance and structure for the data committee in terms of how to approach this. So we're really curious, knowing what using the collective wisdom and experience from the committee members, what are your ideas for how to go about collecting this data? Do you know where it's already being collected in jurisdictions and precincts? What strategies there may be to get it, unified somewhere? And essentially we're, we don't have this data yet, in HCA as part of what we have access to. And so we need ideas for how to put this in the plan, how to get this data, how to make this really functional for the plan. So we're just going to start that conversation here. The data subcommittee is likely, is going to continue that conversation and dig more deeply into it, but would love to get some high level ideas for where to begin with these data pieces. So just going to open that up now. Hallie, is that your hand for this piece, or is that still up?
It looks like she may have stepped away
Oh, okay.
for a
Hallie,
moment.
oh, yeah. Hallie, I'm just going to lower your hand. Feel free to put it up if you want to speak. Okay.
Yeah, this is one of those areas that you know, you start thinking about, and it takes some thought on how you want to respond. So if you guys have initial responses to Michelle, go ahead and raise your hand. Otherwise, we'll bring in a few other people to join those of you that are interested, and we'll start getting the reactions at the committee level and bring it back to this larger group. But looks like you got some interest now, Michelle. There's a couple people with hands up.
Yeah, go ahead, Amber.
I just wanted to submit to the committee to please take into account that these people receiving services don't want to really give a lot of information. So I know we need to collect data and it's super important, but if we can just make it as simple as possible and, you know, make it to where the people aren't kind of like, I don't want to receive these services because I'm giving up all this information. And does that make sense?
Mm-hmm. Yeah, I think it's balancing between what would help us administratively, and we don't want to turn people off to the service. And it's a really good point, Amber.
So if you're not a committee member, we would love to have your feedback and during the public feedback portion of the meeting. But otherwise, we're keeping the discussion to committee members for this piece right here. All right. So if there's no additional feedback on this, we can go ahead and move into the public. Oh, sorry. Go ahead, Caleb.
I'm just still confused by this language, and I appreciate Amber's point. So it seems a super important point, but the language you have up here talks about the number of people, but I'm still unclear whether we're talking about tracking individuals over time, in which case you can actually look at the impact, the effectiveness of this intervention, or whether you're going to count services, in which case you cannot measure the effectiveness of this intervention, or whether the law is having a meaningful impact. It's basically impossible. You would have to have incredible population level data and be able to adjust for dozens of historical confounders. So it's a tension that we have. To Amber's point, we do not want to get rid of this thing. I know everybody agrees with that. We do not want to have extensive data mandates on this. At the same time, if you don't track individual level human beings over time, you cannot ultimately measure the effectiveness of this intervention. It can't be done. So that's kind of a fundamental question. You know, I've talked with Senator Dengler and Rep. Davis a year and a half ago about this. I think this law has been purposely kind of written somewhat generally, but this is a potentially massive endeavor that we're undertaking. Potentially, I hope so. And I'm still confused. I don't know if Senator Dengler can speak to this, but I don't understand the political process that is going to result in data informing policy in the fall. The timing isn't there. It isn't possible. So how do you as a legislator make decisions about whether this law goes forward or changes, since we don't have data actually being collected yet, and we won't? So I'm getting to the really big picture, but it seems kind of fundamentally important to think about data to understand the context and the uses of those data.
So considering that tension, Caleb, are you more, if you were to provide a recommendation, one direction or the other, like what advice do you have for this piece of data collection currently, or is there anything you'd like us to take away and consider for the plan and for the data piece?
Well, I'm trying to speak to intent, and I'm trying to understand what is needed politically for this to actually have an impact, and I'm trying to understand at the local community level what is needed to have an impact. I feel that without data, which I don't see how we're going to have in time, we're going to go back to everybody's gut political instinct, particularly when it comes to criminalization of drugs. And that the impact of the services that are not really being delivered yet, and the fact that there's modest delivery of those services and we don't have outcomes data, it's going to result in the law being deemed a failure because there hasn't been substantial change. And that with that, we would go back to recriminalizing drugs because the law was a failure. So I'm talking high level, which is the level at which I know Senator Dengra thinks about this work, but I can't speak to these data collection things, and I do know data fairly well. But if I don't know the political and practical context at the state level and the local level, I can't interpret this. I don't know what to do with it.
Mm-hmm.
Yeah. Caleb, let me try to address this real quickly, and then we'll move on to get a response. I think Senator Dinger had her hand up earlier, and a couple other people do as well. I think Tony addressed it earlier in the meeting where he was talking about what we can collect from an outreach person as part of Recovery Navigator. Those initial contacts, back to Amber's point, you can't ask 1,000 questions to the first person you meet on the street kind of thing. What we can do from outreach, and then what we can do once they come in for case management. And I think in the case management, we can start to get more detail and maybe be able to follow up with folks a little easier than on the outreach side. But again, we can get more into detail on that. Bigger picture, Senator Dinger, did you have a response for Caleb's larger question?
Yes, and I'm going to try to be brief because Caleb, I can talk so long about the bigger picture. So I see data in multiple formats, right? We need data so that we know what kind of services providing, to whom we're providing, the impact of the services, a lot of what everyone has already mentioned. That, while that data is helpful for policymakers and legislators, there is also, best practices that are already known. There are lots of studies out there that already show us that criminalization does not result in reduction of drug use, right? We have decades of that experience. So I think the data collection serves multiple purposes. And when we're taking a look at what kind of data we want to collect, I think we have to look through the lens of, I really want to talk about access to treatment and best practices and being able to impact humans' lives. To me, that's what's important. On what the legislature does, I don't think anyone thought that this bill would be up and running and the services provided in the short period that we had when we implemented it to when the report is due. It is a lengthier process. It's a longer conversation, and as I mentioned, there are already best practices out there that we can learn from around the country, internationally, on what's working in certain aspects in different parts of our state. The law does expire. It expires next year. So the legislature has to take action. And so what my hope really is, and I'm glad Senator Braun is here as well, is that there are going to be recommendations coming out of here for us to see what is currently working. I'm glad that there are pilot programs that are already running in the 4 or 5 counties that were mentioned, and seeing what that looks like. So there's a lot of information out here, and it's going to serve a lot of different purposes. One of that only is going to be to the legislators, but that's where I think those recommendations that are going to be made in this will be helpful.
Thank you, Senator. I see a few more hands. What this means, folks, is this is really a critical conversation, is the public input time will limited probably to the last 10 minutes of the meeting, and we'll spend another 5 minutes on getting feedback with hands up. This is a really important conversation. So next up, we're going to go to Marshall Glass.
Hi, everybody, and I appreciate the comments so far. So one question I have is I understand that the behavioral health supplemental data that the state is collecting from all the BHAs is after somebody has engaged in services, but a lot of that data that is being collected as part of BHSD really hits a lot of these different elements that are listed on this slide. So my question is, how can we utilize the behavioral health supplemental data with this data that will be collected so that we're not doing duplicitous work?
Yeah, good question, Marshall. And I'm sorry, Michelle, I've just kind of taken over here. I think it was showed earlier that where, again, Tony and Michelle were going over, and Suzanne, that we tried to link these to the BHDS data. So many of the things that we're asking for should be congruent, Marshall, with what you just asked about. We're pulling many of the same elements over, and the definitions are the same. Little easier to get in treatment than in some of the outreach activities. And I think that's part of the challenge right now is what can we get when without overburdening the people we're trying to serve. So does that make sense?
So is there a way to reduce the burden on the providers of submitting data for individuals where the data has already been collected?
Given the time, I think we'll take that back as a question. Possibly. You know, it's, yeah, that's kind of a complex response, I think, that we'll have to think about how to address. So if we can take that one back, a lot of times what you have is a different providers providing different services. And so the basic demographic kinds of information are probably being collected multiple times along one's journey. But let's get back to you on that. So if that's okay.
Absolutely. Thank you.
Yeah, absolutely. Brandy Flood.
Yeah, I think you guys touched on my first question, which is Caleb put in the box, there might be some other ways to collect data. But I was going to tell Amber, like, there's some other ways we can do it where you're not asking people a bunch of questions and over long-term case management, get all that information. But the bigger question that wasn't answered for me is, what is the end game for the legislation to move this forward? So I know for communities, I could say that we want to see people getting robust services and not doing jail time for drug use. But what is your guys' money factor to keep this kind of program going? If we knew that end game ahead of time, you can, I think what Caleb is saying is construct the data to be able to collect that. Because you guys already know what you need to push this forward after a year, even though people are not saying it. But at some point, we want you to say it, so we're collecting the data in the right way. What is the end game now? So we're set up for success and not failure.
Thank you, Brandy. And Senator Braun's up next. I don't know, he may have a response for you. I'm not sure, but his hand's up a little bit earlier than that too. So, Senator.
Well, thank you. And my comments may be kind of overcome by offense, but I think I want to go back to this data collection issue, because I think I may be in this very small minority in this group that I think we're moving perhaps too quickly in decriminalizing some of this. And I don't mean that in a way that we want to go back to, war on drugs. I think that's wrong. I just think if we move too quickly without solid data, without really understanding the effects, the individual effects of some of the proposed actions, we could do more harm than good. And so I have deep concerns about whether we are collecting the data. I think the concerns, in time, accurately, and I don't think, we can go out there and kind of self-select the studies that support our preferred policy option is going to really solve the problem. And I think more importantly, we're going to be faced with a political issue a little less than a year from now, where folks are going to have to decide, folks being legislators, are going to have to decide, how do we follow on when this policy ends in just over 2 years. And I think there's not enough data. I mean, consider me a test case. No one's convinced me that this is the right path yet. I'm not convinced we shouldn't go nudge along this path, but to do it at the speed that's currently being suggested, I think is very worrisome, problematic, and politically difficult. So we got a real problem with data. I think you're going to end up, my prediction is you're going to end up with not a data-based decision, but a political-based decision that may or may not be a good decision. So that's my input for what it's worth. I look forward to participating. Thanks.
Thank you, Senator. Okay. At this point, I think we will open up to public comment. I see 3 hands up, but I believe they just haven't come down yet. So a lot of good discussion. If I could twiddle my nose or something, I'd add an hour on today just to continue this for a bit more time. But really, thank you all for contributing today. We will take the last probably 8 minutes of the 9 we have remaining and see if we have any comments from the guests and public that are here today. Please remember to keep your comments relatively brief. I think we have a 3-minute clock on, and we'll get through as many as we can. So do we have any public input comments? And it looks like the first hand up is Mark Cook. Mark, you're on the clock. Go ahead and let us know what you're thinking. Good to have you here today too, Mark.
Yeah, thanks, Michael. Hi, everybody. Can you hear me okay?
Yes.
Okay, thank you. So my name is Mark Cook. I'm an attorney with the ACLU of Washington. The ACLU of Washington believes that substance use disorder should be treated as a public health issue, not a criminal justice issue. Also want to acknowledge the horrific racial disparities the war on drugs has caused communities of color, both in terms of over-enforcement and lack of meaningful public health alternatives. In terms of data collection, I also just have to note that we've arrested and punished people for decades and decades, and nobody's ever asked police for data showing that they've decreased substance use disorder or decreased overdose death. So just want to acknowledge that, so please be backward looking too. But in terms of this specific work, really just want to give a huge thank to all of you that are participating, both staff and committee members. It's challenging, hard work, but public members are cheering for you and just very thankful that you're doing it. Also wanted to remind the group that this committee really came out of legislation called House Bill 1499. The Pathways to Recovery Act is where this committee really came from, and it was added into Senate Bill 5476 at the last minute. So it really does come from a place of recovery originally, and I would encourage you to all read House Bill 1499 if you can, to really get some understanding of some of the intent behind this committee. And just wanted to note a couple of the specific parts of the legislation itself, reading verbatim here. The proposal of a funding framework in which over time resources are shifted from punishment sectors to community-based care interventions such that community-based care becomes the primary strategy for addressing and resolving public order issues related to behavioral health conditions. Further, recommendations regarding the appropriate criminal legal response, if any, to possession of controlled substances, end quote. So these are really, fundamental issues that this committee is supposed to be wrestling with. It is not a paint by numbers exercise. You really are supposed to be wrestling with what is the right response to substance use disorder. And I encourage you to, be broad in coming up with a plan. It is not a report. It's a plan. It is recommendations to lawmakers and to the public for what we know, really helps people that are struggling with substance use disorder. So be broad, engage the public. There are people that want to help, that really want to see this work succeed. So I think that is the main comment I wanted to make, is that, just lean on each other, be bold here, try to get the work done. Don't look at this as, just a piece of legislation that the motions need to be made to get through. It's really trying to fundamentally change how we treat these issues in the state of Washington. Thank you.
Thank you for your comments, Mark. Do we have other public comment this morning? Okay, I'm going to go to Lisa Ray Thomas. Lisa?
Thank you so much, and thank you to all of the SURSAC committee members. And I really want to extend my appreciation, gratitude, and respect to Hallie, Brandy, and others who are making courageous statements and encouraging and really challenging everybody to think outside the box and to work together. And right now I'm speaking as a member of the Tlingit tribes, so a member of the Indigenous community. And I want to acknowledge that Vicki Lowe has joined the meeting today. Vicki is the Executive Director of the American Indian Health Commission of Washington State, and having American Indian, Alaska Native, tribal, urban Indian healthcare provider perspectives, guidance, and what's the other word? As part of this process is really important. So I really want to extend my appreciation to Vicki for her time in joining the group today. And thank you all for this great work that you're doing.
Thank you, Lisa. And thank you, Vicki, for being with us today. Other public comment? Okay, I'm not seeing any other comments or hands raised from the public. Brandy, I do see your hand up as a member. Do you have a comment, or was that up before?
No, I put in the chat. I'm having a hard time lowering it on my computer. Now I don't want to lower it. I don't have a comment.
Okay, thank you. Thank you. We have about a couple more minutes if there's any other comments today. Yeah. So my comment is we are in it now. We've gotten to know each other a little bit. We've gotten the charge of what the group is about. And now I'm going to say that challenging and complex, but also energizing and fun work is amongst us, right? This is all cool. This is stuff that we get to dig into and talk about. And for some of us, we wanted to talk about this for a very long time. So please take advantage of the opportunities of joining the committees. If you can just do one, that's great. If you can do more than one, you're more than welcome. Let us know if you're interested in co-chairing the committees. We want to know that as well. And again, as mentioned before, Michelle is here to support the committee. If you have thoughts, concerns, questions, ideas between time and you want to reach out to her, please do so. Or as the chair, I'm happy to take your thoughts as well. Michelle, I'll turn it back over, I think, to you for the last moment. But really, again, appreciate you all being here. And for our legislators on, thanks for getting us through session. And impressive you're on so quickly after, but I hope you've had a few minutes to rest. And thank you for engaging today. So Michelle, back to you to close out.
Yeah, I just want to say, as the administrator for the committee, you can be expecting more consistent communication from me from here on out. So I hear you absolutely that you're not feeling clear about how your feedback is being used and processed. And so I'll do a much better job communicating that back to you so that we're all on the same page there. And again, I highly encourage you to sign up for the subcommittees. And we expect there will be significant overlap with members between the committees. So hopefully that will decrease any sense of siloing with ideas, and there will be lots of communication happening in between members of various subcommittees. So look forward to working with more of you in those contexts as well. Keep an eye out for the 2 emails from me about the subcommittees and also the Recovery Navigator Program feedback conversation that we didn't get to wrap up quite today. So I think that covers it. Again, thanks everyone for your participation, for being here, and your super, incredibly valuable feedback with all of this. All right, bye.
Thank you, Michelle. Thank you, everybody. Have a great spring break if you're taking a little time off, and enjoy the weather. So take care.
Take care.